Good evening, everyone. Thank you all for joining us for today's webinar, Living with Polycythemia Vera. This is organized by the Florida Society for Clinical Oncology, or FLASCO. FLASCO is a member-supported state society that focuses on supporting and representing the oncology workforce of Florida. Together, FLASCO is the voice of oncology in Florida. And all of us individuals presenting in this webinar are members of FLASCO, and we appreciate their support. My name is Dr. Andrew Kirkendall. I'm an assistant member at Moffitt Cancer Center in the Department of Malignant Hematology. Our topic today is living with polycythemia vera. I'll serve as this evening's moderator and keynote speaker and discuss the disease itself, treatment options, and where we're going with this in the future. We'll then move on to more individual focused areas and invite Seth Bergowitz as well to chat about caregivers advocacy and resources. And certainly have some room to talk to answer some questions as well. So before we begin the presentations, I'd like to thank PharmaEssentia for sponsoring this webinar and making it possible for us to share this important information. I'd also like to let everyone know this webinar is being recorded so that those who are unable to attend can view it in a later time. Please note that your lines will be muted for the duration of the webinar. Towards the end of the meeting, we'll host a Q&A, and we encourage you to submit questions or comments via the Q&A chat feature at the bottom of your screen. And we'll try to discuss as many questions as time presents. So I'll provide today's first discussion and provide kind of an in-depth overview on polycythemia vera, the disease really from an academic specialist perspective. And then we'll discuss various treatment options available and the future of this disease. So let's chat a little bit about what that means as far as polycythemia vera, the disease. I think this means a lot of different things to different folks. And I'd say from someone who focuses a lot on polycythemia vera, I have I guess to give some background. So I'm a clinical researcher at Moffitt. My specific focus is on myeloproliferative neoplasm patients. I have clinic 2 days a week. I spend the rest of the time kind of following up on clinical issues as well as doing clinical research. That includes clinical trials, doing retrospective research, collaborating with other folks, both in the United States and outside the United States to better understand this disease, better understand risks of the disease, and kind of identify future treatment options for this. So with that comes a decent amount of experience of seeing polycythemia vera patients. We see on average between 150 and 200 new patients with polycythemia vera each year at Moffitt. And we've come to really a better understanding over the past decade of what this disease really means and how we view it. And so for a long time, I think this disease was defined or described by having kind of too many red blood cells. And certainly, I think if you look at the WHO criteria for diagnosing polycythemia vera, it's still a key component of the disease. Patients have to have a certain level of hemoglobin or hematocrit to meet the criteria to have polycythemia vera. But really, the disease is so much more than that. And I would say that polycythemia vera is really the quintessential myeloproliferative neoplasm in the sense that what you have is a true overproduction issue, and it's not limited to just red blood cells. We know that virtually all patients with polycythemia vera have disease that is driven by a JAK2 mutation. JAK2 is a protein that is inherently involved in blood cell production and inflammatory pathways. As you can imagine, that blood cell production is something that you do in many cases when you are dealing with inflammation. So we know that in inflammatory instances, white blood cells go up, platelets go up. That is something that your body helps to fight an infection or respond to infection. And so to think that blood cell production and inflammation are tied together is relatively obvious when you think about it, but may not be outright obvious off the outset. And JAK2 is a protein that is inherently associated with the production of red blood cells, platelets, and white blood cells. And so when you have this mutation, though, instead of making those cells when you need them, right, for inflammatory purposes or needing to make red blood cells or deal with kind of bleeding and making platelets or something like that, you're now kind of making these blood cells all the time, right? So you've now flipped the light switch on and you're constantly pumping out, it's in these cells that have these JAK2 mutations, you're constantly feeding the flame of pumping out red blood cells, white blood cells, and platelets, and these Really, the disease starts in these underlying hematopoietic stem cells and gives rise to increased burden of disease. And so when you think about this from just an overwhelming proliferation picture, it explains what the bone marrow biopsy looks like as well. So when you go and look at the bone marrow biopsy, what you see is a hypercellular marrow. This is kind of, the bone marrow is your factory for blood cell production, right? So you see this hypercellular marrow that is just full of blood cells, red blood cells, white blood cells, granulocytic cells, megakaryocytes, or platelet-producing cells. And we call it panmyelosis, meaning just overproduction. And then what you see in the peripheral blood is you see a really high hemoglobin, hematocrit, you see high white blood cells, high platelets, and you see kind of just an overwhelming amount of cells. And then clinically, what we see is quite variable, right? So some patients have no symptoms at all. They just kind of incidentally get diagnosed. Other patients get diagnosed because they feel a ton of fatigue and to get it checked out and find abnormal blood counts. Others have maybe more kind of objective symptoms like itching, fevers, chills, night sweats, bone pain, and maybe that's what drives them to seek care and ultimately get this diagnosed. And others may present with some sort of clotting issue. So we know that anything that drives inflammation can increase the risk for thrombosis, and polycythemia vera is no different. JAK2 mutations lead this overwhelming blood cell production, increased activation of inflammatory pathways, and thus an increased risk for blood clots as well. And so many patients will present with some sort of a blood clot, be it a DVT in the veins, in the lower legs, a pulmonary embolus. Sometimes it could be something more severe, such as a stroke or a heart attack. Oftentimes, patients can present with weird blood clots too. So clots in the abdominal veins or in the veins that surround the brain. These are kind of weird things, but often are associated with myeloproliferative neoplasms. So symptom-wise, we can see certainly a variable amount of things, but all of this is tied to kind of this overwhelming increase in inflammation. And so I think when we think about the disease from kind of the academic perspective, it's no longer just about an increase in red blood cells. That certainly does happen. But we have to think about this from the core is there is a underlying mutation that's involved in blood cell production and inflammatory pathways that has been turned on and activates kind of this overwhelming blood cell production as well as overwhelming inflammation that leads to a full bone marrow, clinical symptoms, and an increased risk of having thrombotic events due to this kind of unchecked inflammation. The kind of extension of that is we also have to think about the fact that this disease can progress, right? So polycythemia vera may be the initial diagnosis and maybe something patients live with for a long time, but ultimately patients with polycythemia vera can progress to most commonly myelofibrosis. And myelofibrosis to me is kind of the natural end result of having long unchecked inflammation going on the bone marrow. All that inflammation leads to increase in scar tissue, fibrosis, leads to an inhospitable bone marrow environment. You start to make blood cells in other locations, such as the spleen or the liver. And ultimately, you're not able to make blood cells as well as you used to, right? So instead of having high blood counts, now you start to have low blood counts and run into different issues. Again, symptoms can be present with polycythemia vera, but they're more likely to be seen with myelofibrosis. Less commonly, we see polycythemia vera patients progress to acute myeloid leukemia. This happens quite rarely, maybe 2 to 3% of the time. And to me, the less of a natural progression and something that's more akin to another mistake happening or a new mistake occurring. So really to transform from polycythemia vera to acute myeloid leukemia, you need another mutation other than the JAK2 mutation. You need some other mistake, some other genetic event, and typically these things are things that happen somewhat at random, but with increased frequency in polycythemia vera. And maybe that makes sense because these cells that have the mutation are turning over more rapidly. There's more chance for these mistakes to be made. And so we do occasionally get this progression to acute myeloid leukemia. So I think going back and thinking about how we view this disease, we view this as a chronic inflammatory disease. It is a hematologic malignancy, but we view it as a chronic inflammatory disease that increases the risk for thrombotic events, has an increased risk of progression over time to myelofibrosis or rarely acute myeloid leukemia. But we have to think about this and what can it do currently, what is it doing currently? What could it do in the short term? And what are our long-term concerns as well? And I think when we talk with patients in the clinic, these are things that we have to bring up and kind of talk about in its entirety, because I think it's what makes this disease really challenging, both for physicians and for patients, right? It's difficult to kind of weigh all these different considerations and think about, how do I maximize my quality of life now? How do I protect myself from future events that could really impact my quality or duration of life? And how do I kind of grapple with the feeling that this disease could progress in the future? And so I think that now I'll kind of shift a little bit from talking more about how we view the disease to talking about how do we approach and treat the disease, because certainly it's going to kind of fall back on some of these things I recently touched on as far as acute concerns versus more long-term concerns. So how do we treat this disease? Well, I would say the kind of historical paradigm of treating polycythemia vera is to reduce the risk of clots, right? Is to stop people from having blood clots and heart attacks and strokes. And that's really what people have kind of said, that's kind of like the test answer, right? If there's one goal, that's our goal. And I think that's probably short-sighted. That's not really entirely what we're going for these days. I think our aim in treating this disease has certainly expanded over the past decade or so. But in many ways, that is kind of still often our primary goal. And I'll go back to these three issues we talked about before with understanding the disease. First, we have ongoing clinical symptoms that can affect day-to-day quality of life. Then we have the risk of developing thrombotic events, which can take a disease that has an otherwise relatively good prognosis and really minimize the quality of that prognosis, right? So in someone who has a good prognosis from the disease, but they develop a heart attack or a stroke, that changes things immediately, right? So I think it's a vested interest for us to try to prevent that at all costs, to be able to allow patients to see that long-term quality of life. And then lastly, we have to think that our aspirational goal would be to prevent progression of this disease. Now, I'll tell you that that's been quite limited in our ability to do that, but certainly we need to keep that in the back of our minds, because we need to be developing therapies that have the ability to stop the progression of the disease, maybe even eradicate it in its place right now, but certainly stop it from progressing to things like myelofibrosis and acute myeloid leukemia. So we'll take these things one by one. So first, let's talk about how do we try to prevent patients from having a thrombotic event. And we do so in a number of ways. And each are based on some degree of data. Some data is better than others. But first off, I think that the question is, is there a safe hemoglobin level, right? So we often say that we do three things to prevent thrombotic events. We do aspirin, phlebotomies, and some sort of cytoreductive therapy in quote unquote high-risk patients. And so first, let's talk about aspirin. So the data for aspirin comes from a study called the ECLAP trial, which was a European trial looking at the benefit of low-dose aspirin in polycythemia vera patients. And even a trial that didn't completely enroll, what it was found is in patients that were randomized to be on baby aspirin compared to not, actually had about 3- or 4-fold less incidence of cardiovascular events than those that were than those that were not on aspirin. And so from that standpoint, we recommend everyone be on a baby aspirin. I often get asked, well, what about taking a full dose aspirin or something like that? The studies that have been done on full dose aspirin say that it doesn't really get too much extra benefit than a baby aspirin, but it causes increase in bleeding. So we typically stress just a low dose baby aspirin in those folks. Now, what about phlebotomy? Now, we typically do phlebotomies to keep the hematocrit less than 45%. Some would argue in women try to keep it below 42%. This is based on the CYTO-PV study, which randomized patients with phlebotomy to either keep their hematocrit less than 45% or to keep it between 45 and 49%. And those where we kept with a more strict hematocrit control ultimately had fewer cardiovascular events, again, by about 2- to 3-fold in this case. So that kind of set the stage for why we try to keep hematocrit less than 45%. Now, both of those things make sense. So, right, we know that in polycythemia vera, you have increased amount of red blood cells. When you have an increased amount of red blood cells, that leads to a thicker blood per se. That hematocrit is a measure of the amount or the percentage of your blood that's made up by red blood cells. When that gets to be quite high, the blood kind of slows down. It's a little thicker, more likely to stop, and blood that doesn't move clots, right? So you run into that risk. Aspirin is a platelet inhibitor. In myeloproliferative neoplasms, you have an increased amount of platelets. They're highly active platelets. They're ready to stick onto blood vessels and capture a bunch of their friends that are platelets and cause clots in arteries that surround the heart. And so if you inhibit those platelets, maybe you allow those platelets to freely flow by each other and not aggregate and cause acute clots. So while we do have good data that suggests that patients on baby aspirin and getting phlebotomies have less clots than others, it also makes biological sense. So then the last thing we do is cytoreductive therapy. And typically this has been recommended for patients that are high risk, right? So high risk we define as over the age of 60 or a prior thrombotic event. So this actually ends up being most patients, and since most patients are diagnosed kind of in their 60s or older, and many have had a thrombotic event before, or that's what led them to diagnosis. And so cytoreductive therapy is typically meant one of three different options. So we have our old favorite hydroxyurea. We also have interferon formulations, which I'll broadly lump as a group, even though there's different formulations. And then we have ruxolitinib, which was approved for a second-line treatment of polycythemia vera in the early or the 2010s. So the data for hydroxyurea actually comes from probably the mid-80s. They did a study in this polycythemia vera study group called the PVSG in the 70s and 80s, where the initial study was seeing what was better at treating polycythemia vera. Was it better to give people phlebotomies alone, or to give them like radioactive phosphorus or some sort of chemotherapy like busulfan or something like that? And what they found out is if you give people radioactive phosphorus and busulfan, it's a really good way to give them leukemia. So maybe not a great idea there. But what they realized is that patients who just got phlebotomies had a lot of clots. So if that was just what they were getting and nothing else, they tended to still have a lot of clots. And maybe it was because not all those patients were on aspirin, and certainly not all those patients were treating to a goal of less than 45%. But when they compared that to the patients that were getting the chemotherapy, they realized that those patients actually had fewer clots, even though they were more likely to die of acute leukemia. And so then they kind of ran it back and said, well, what if we do a study where we just look at maybe a kind of a cytoreductive agent, something to control the counts that doesn't have real big, strong chemotherapy-like properties that would cause DNA damage. And so that's where they looked at hydroxyurea. And lo and behold, it took the thrombotic risk down from, say, 5 to 6% per year down to close to 1 to 2% per year. And hydroxyurea probably accomplishes this through a number of ways. It probably helps to lower the blood counts and keep them stable, at better goals. But also it actually has some effects on blood vessels themselves. So it causes increased nitric oxide to be released, which relaxes blood vessels. That's why we also use hydroxyurea for patients that have sickle cell disease, because it decreases their risk of pain crises, where you get these microvascular clots that cause a lot of pain and ischemic-like pain. And so hydroxyurea probably has different ways that it works to prevent thrombosis that we don't fully understand. The next option I'd say would be interferons. And so interferons have been agents that have been extensively studied in the late 80s and early 90s. And we know they help to control blood counts and in some cases, like in CML and maybe long-term treatment of polycythemia vera, it's been able to kind of perform some impressive reductions in the disease burden in a small number of patients, but historically it's been challenging due to side effect profile. So in the late 80s, early 90s, it was given 3 times a week, large doses. You had a lot of spikes and troughs of the interferon in patient systems, and ultimately, even though it helped to control blood counts, people felt terrible. A lot of flu-like symptoms, fevers, chills, night sweats. Got a lot of liver enzyme elevations, exacerbations of autoimmune diseases, worsening mood symptoms, worsening depression and anxiety. People that had psychotic disorders, those got worse. And so really not a well-tolerated medication at that point in time. But then we got better at actually making interferons. And so they formed a pegylated interferon, which is this formulation that allows for less frequent administration and more consistent levels. And so it's given at lower doses. And instead of the spike and trough situation, you get kind of this gradual low dose, and you give this subcutaneously once a week. And what we found there is actually we can get away with using a lot lower doses and still get the same blood count control one might see with the other interferons, but we don't get a lot of the toxicity. And so some of the toxicity in terms of flu-like symptoms was rapidly mitigated. We still see some LFT abnormalities. We still have some caution in patients that have mood disorders or autoimmune disorders, but certainly less of those really terrible side effects that we saw in the early stages of interferon. Now, recently, we've had the approval of ROPEG interferon, otherwise known as Besremi, that was approved in November a couple of years ago. So going on one and a half years of being approved at this point. And ROPEG is really kind of an extension of the interferon story. So we've now formulated it in a way that it's given even less frequently. So once every 2 weeks, again, having less of the spikes, more of the sustained drug level in the system, which really minimizes some of these side effects even further. And ROPEG was studied in several studies, the main ones being this called the PROUD PV, which led into this continuation of the CONTI PV study. And it was studied compared to hydroxyurea. And what it ultimately shows, a pretty complex trial to figure out how to analyze it, because there's some nuances there. But basically, at the end of a year, ROPEG was similar to hydroxyurea in blood count control. So about the same. So both Hydrea and ROPEG can control the blood counts the same at about a year. But the intriguing thing is if you look at 2, 3, 4 years down the road, ROPEG does a better job at having sustained blood count control. And we saw encouraging reductions in the JAK2 allele burden. So the amount of cells that had that JAK2 mutation in them actually tended to go down in patients that were able to be on the medication for longer than say 2, 3 years. So it takes long-term exposure to get these these results in terms of the JAK2 allele burden. And I would say we're not exactly sure what the JAK2 allele burden means, that it's going down, but we tend to think that's not a bad thing. That's the amount of cells that have this mutation are going down over time. But we really don't have yet the real long-term data to suggest that there's truly a decreased risk of progression to myelofibrosis or progression to acute leukemia. Although certainly I think that there's the thought that there is, especially in those patients that can tolerate being on it for a long period of time. Now, despite the fact that ROPEG is better formulated, it doesn't mean that it's completely without side effects. Certainly, we still run into the fact that it can cause itching. We know that it can still cause liver enzyme elevations, exacerbation of autoimmune disease. So we have to be cautious when giving it, and certainly monitor the dose ramp up that comes with this medication. But I think this is an improvement on prior interferons. And I think interferon itself offers more long-term benefit with the data that we've seen so far than other agents. So then we get to our last approved agent for polycythemia vera, which is ruxolitinib. Now, ruxolitinib is approved for myelofibrosis. It's in the class of drugs called a JAK2 inhibitor. So it inhibits the inflammatory pathway that is upregulated in polycythemia vera. And it got approved based on a trial called the RESPONSE trial, where in patients that were either intolerant or resistant to hydroxyurea, they were put on ruxolitinib with the goals of both reducing their need for phlebotomy by controlling the hematocrit and actually decreasing the size of their spleens. Now, not everyone with polycythemia vera has big spleens, but this is something that it did in myelofibrosis, so they figured let's look at it there in polycythemia vera. And ultimately, it's very good at doing that. So, and much better than doing that than the best available therapy was at the time. And so, ruxolitinib is very good at controlling hematocrit. It did so in nearly 60% of patients on that trial. Reducing spleen size did so in a strong minority of patients on that trial as far as getting a true spleen response, and was able to achieve the tandem end goals in about 20% of folks. And so, but then the kind of drawback to that study was, well, okay, so you showed that it reduced spleen size, but we don't really care about that often in polycythemia vera patients. Show me that this is good for patients that just have polycythemia vera without big spleens. And so they ran another trial called the RESPONSE 2 trial, which was in patients that didn't have splenomegaly. And again, it was shown to be a very effective drug in controlling hematocrit. In both those studies, they did look at patient-reported outcomes and symptom improvement. And what was seen is that ruxolitinib, similar to its impact in myelofibrosis, is very good at controlling disease-related symptoms such as fevers and bone pain, abdominal discomfort, abdominal distension. Itching is a main one. It's a very good anti-itch drug. And so when we think about these three agents I talked about, Hydrea, interferon, and ruxolitinib, they're three very, very different agents. They do very different things. And so when it comes to treating patients with polycythemia vera, it's really something we have to individualize that therapy to think about what agent makes the most sense for the patient sitting in front of me. If someone presents with kind of elevated hematocrit, tons of symptoms, itching, fevers, chills, night sweats, maybe a big spleen, Jakafi or ruxolitinib makes a ton of sense for those folks, right? That's something that we think can give them immediate benefit. Now, if someone else presents with need for phlebotomy, otherwise asymptomatic, kind of in their 70s or 80s, Hydrea makes a ton of sense, all right? It's cheap, it's easy, it's well tolerated, we can control the counts. Now, in a younger patient who doesn't have a ton of these more proliferative symptoms, but really is concerned about the potential for long-term disease progression, perhaps that's someone where interferon makes a ton of sense to be able to achieve or delay progression of the disease over time and help to control the counts along with that. And the cytoreductive therapy, as I mentioned, goes hand in hand with therapeutic phlebotomies to keep the blood counts controlled, as well as a baby aspirin in those that can tolerate it. And so that's kind of the overview quickly of the treatment approach. And I'll lead it into kind of the last section that I'll talk about right now, which is really talking about the future of polycythemia vera. So I think looking at what I talked about with interferon, as far as this potential ability to delay progression of the disease, that is where I think the future is going, right? I think that we've kind of maxed out our focus on reducing clots and stopping people from having clots, right? I think we do that relatively well right now, but we I think as a community understand that the goal really should be on living longer and living better. And from that, we need to think about hitting this disease at its core. We certainly understand the disease a lot better than we used to. And so we need to leverage that information, that understanding into novel therapies that are able to stop this disease from progressing. So I think you're starting to see with ROPEG interferon a focus on that. And certainly I think that there's room to improve on understanding how to combine ROPEG with other agents, such as ruxolitinib maybe, so that we're not just delaying disease progression, but we're also maximizing patients' quality of life and symptoms. We know that ROPEG can be helpful for controlling counts and potentially for delaying disease progression, but oftentimes patients don't feel a ton better when they're on it. And so in those patients that have a lot of symptoms, we'd like the ability to maybe combine ROPEG with ruxolitinib. We also need to better understand if ruxolitinib by itself can delay disease progression. There was an interesting study presented at ASH this year that showed that allele fraction reductions can also be seen in patients that are on long-term ruxolitinib. And that makes some sense. This is an anti-inflammatory that may be able to stop that inflammation and maybe lead to a less of a survival advantage for those cells that have the JAK2 mutation. As far as other agents that are being developed currently, I think that there's a lot of excitement around PTG-300, or a drug called rusfertide. This is a drug that's a very specific niche, right? So this is a drug that is really aimed at decreasing the need for phlebotomies. I often talk to patients about the fact that phlebotomies are a necessary part of treatment. I mentioned it as one of the key kind of pillars of the treating polycythemia vera. But also that's kind of crazy, right? That's kind of archaic in the sense that one of our key treatments is to actually like bloodlet folks and take blood from them and tell them that they're safer after we've done that. To many patients, that's not as easy as it sounds. I mean, in a perfect world, yeah, you'd be able to walk in, take some blood, you'd walk out, you'd be done in 30 minutes. But in practice, that's not how things work. Oftentimes, patients have to come in, get their blood count checked to see if it meets criteria for needing a phlebotomy. That may take hours to figure out. Maybe even they get called at home and say, hey, yeah, your numbers are up. You got to come back on a different day, or you got to wait on the same day that you had it checked. Then they got to get you into the lab, set you up for an appointment. Sometimes a lot of places don't do phlebotomies, right? So some patients have to go to the ER in order to get in there just to perform a phlebotomy. So this is something that can take days, and certainly not something that's super conducive to living a functional working life. And so patients that have full-time jobs find this to be very, very challenging. Other times people have challenges actually tolerating phlebotomy. So many of our patients are older and they don't tolerate fluid shifts very well. So if you take a half liter of their blood, what tends to happen is they get very lightheaded and woozy and they may pass out. Maybe they have poor veins and it's hard to get access, and to get sticks every once in a while just to get lab draws or phlebotomies is not really an option. So then they're asking whether or not they can get ports placed or PICC lines placed. In a patient who's already at risk for clots, we're going to put an indwelling line in there to make things easier. That doesn't make a ton of sense either. And so rusfertide was really developed as a way to control blood counts without the need for phlebotomy. And it's actually a peptide therapy. So it's something we call a hepcidin mimetic. So hepcidin is a protein that is involved in iron regulation. Obviously, you need iron to make red blood cells. One of the problems we run into with phlebotomies and doing a ton of phlebotomies is we make people profoundly iron deficient, and we call that a win. But then there's symptoms that come with iron deficiency, such as restless legs or craving ice or fatigue, maybe decreased concentration. So perhaps this is a way of kind of mitigating some of those concerns we have with recurrent phlebotomies. And so rusfertide right now has been studied in a phase 2 study that's looked to be quite promising. Patients who went on the medication had to be requiring a significant amount of phlebotomies. And what was seen is after they started on this medication and had it titrated, they virtually didn't need those phlebotomies anymore. They needed them much less frequently. This has really been associated with a small improvement in symptoms as well, and something that could really change some people's lives. Is this great for everyone? Is this going to transform the care of polycythemia vera for every patient? Probably not. But I think there is a significant, minority of patients that struggle with repeated phlebotomies, in which case this could be a welcome addition to the armamentarium. I think the last thing I would touch on from a polycythemia vera standpoint, as far as future therapies, is we had some interest. I mean, many people ask, well, why don't we just do some sort of gene therapy, right? We know that the problem's in the genes. Why don't we just replace that? And I think, for a long time, we that's an idea, but you do need JAK2 to make normal blood cells. So you can't just get rid of the gene, but we do need to figure out a way to target the mutated gene, which is proven quite difficult. But I think that there's progress being made there. And I think what we'll see in future years, maybe in the next 5 years or so, is we'll start to get drugs that do a better job of selectively inhibiting the mutated form of JAK2, and in doing so lead to more disease modification from that standpoint going forward. So I think that the diseases, our focus of the disease is shifting. Instead of just trying to prevent clots, we're really trying to impact the underlying disease, and we're doing so with kind of leveraging our understanding of interferons. We're doing so with kind of considering mutation-specific inhibitors of JAK2, and potentially other different ways of getting after mutated form of JAK2. But also we need to keep in mind that our goal for many patients is to improve their quality of life. For many patients, polycythemia vera does not come with a decreased length of life. They're going to live normal life expectancies, but they may live with worse quality of life. And so we need to consider that as well going forward, and finding the right combination of both of those will be quite important. So that brings me to the end of those 3 topics, and hopefully, I know I went kind of rapid fire, but hopefully it's spawned some questions that can come up in a future section when we do the Q&A. I do want to now kind of shift things over to the topic of patient assistance programs and caring for the caregiver. And with that, I'll actually welcome Seth Berkowitz from the Leukemia and Lymphoma Society to highlight those important resources.
Thank you very much, Dr. Kuykendall. Great presentation. So, I think one of my goals here today is to really help answer patient questions, and I'm going to go over a few key points and of discussion, and then kind of go from there. So I'm going to start with the caregiver piece, because I think caregiving is really important. And when you're talking about someone who's going to live a long time with their disease, like a patient with polycythemia vera, if you're the caregiver for that person, you really have, you're in a marathon, and you want to really work with that person and really figure out what works. So something that's really important is just acknowledging that person has the right to make decisions about his or her own life. And while you're certainly, as the caregiver, can give input, they're struggling for control and want to have some control over their decisions. And so, they have to have that right, to make those decisions themselves. Whenever possible, they're trying to do everything they did for themselves before. So offering them choices, letting them do the things they can do. We know that people who are going through treatment may not be able to do everything they could do before, but they want a sense of normalcy. Be prepared to do what you promised to do for them. And I think the most important thing probably of all these things that I'm talking about are the next two, which is to take care of yourself. Self-care is important. And if you're not taking care of yourself while your loved one is going through treatment, especially with a long chronic disease treatment profile like this, you're not going to be in a position if you get sick to take care of them at all. So it's really, really important. And give yourself a break. No one should be a caregiver 100% of the time. Lean on friends, family, paid caregivers. There's a variety of options based on your particular situation that you can figure out so that you get a break to do things for yourself. Again, that self-care, because that self-care is really very important. And remember, that it takes a village. So I think we all define family differently, but people have families and resources around them, close friends, people they consider family, and they're there to help and can do things, and they can, ease the burden. Sometimes someone is the best friend who can come by and care for the person. So there's a lot of different options for caregivers to think about in what they're doing. Something else in a chronic disease like this, and I know Dr. Kuykendall touched on it, but we also offer at the Leukemia and Lymphoma Society, and there are other organizations who do it as well, clinical trial searches. And I think having a clinical trial search, if you're the patient, is really important to see what is new, what's coming, and what's innovative. And it doesn't mean, and the goal of our clinical trial support program is not to enroll every patient in a clinical trial, but the goal is to really educate patients about clinical trials and to let you figure out with a discussion with your doctor on what kind of clinical trials options might be appropriate for you. So I think that those are some really good and important pieces that are there. So financial need. We know that, especially with the lung cancer, that the financial burden is there, and with the current changes that are taking place in the environment, the financial assistance is not as rigorous as it once was, but there is financial assistance out there. And the thing I always tell people about financial assistance is, while it's open and you have the option, take it, because that way you have the money in the bank for what you need. We don't want to see anyone going without food, without paying their electric bill in Florida with air conditioning and things, because they didn't have their treatment. And then there are a lot of resources out there that can help figure out what financial resources are available. There are food banks, there's local financial assistance in different areas. So there's a lot of opportunities for financial assistance in addition to those offered by the Leukemia and Lymphoma Society. And the information specialists that we have with the Leukemia and Lymphoma Society are a clearinghouse for all sorts of resources that are available throughout the country. And so wherever you're located, you call them and you ask them what's available in my area, and they know that, and that's their job. And with resources, there are a lot of great organizations out there in addition to the Leukemia and Lymphoma Society, and we maintain a list of other helpful organizations. And I'm just going to mention a few, and I can put the link out in the chat for where you find these, or you can talk to one of our information specialists. And of course, we're always looking for more. If you have one to recommend, you can also recommend them to our team. But we have there's the MPN Advocacy and Education International, the MPN Cancer Connection, the MPN Education Foundation, the MPN Research Foundation, the National Organization for Rare Disorders, which Polycythemia Vera definitely falls into, Patient Power, and the PV Reporter, which is a website with information and resources. So there's really a lot of information and resources out there to help you navigate your disease and make it through the process. So it's just a really good way to look at things. And as things change and you have problems, I think it's really important to also remember that you can be your own advocate. And being your own advocate, there are a variety of ways to do that, but people probably don't know that if you're on Medicare and you're having a problem with Medicare, that your local legislator can help with that. And so that is something that is very important to be aware of and know, and that legislators are there to help. And so it's a really good opportunity. And also that you can, communicate with your legislator when things aren't working, because that's how laws often get changed. It's because a legislator hears about a personal experience of a constituent, a friend of a constituent that they know, someone, and that's often how laws will get passed or changed to better meet the needs of patients, is by letting legislators know that people in their area. And there are a lot of organizations out there, American Cancer Society's Cancer Action Network, the Leukemia Lymphoma Society, and others who have advocate networks. And what the goal of all those advocate networks is to educate you as the patient when there are laws that are being passed or budget considerations that would positively or negatively impact cancer patients. And so I think all of those are really great and interesting things that really can make a difference in how patients respond to a variety of different things. The other thing is, just being mindful when there's Medicare open enrollment. If you have one of these diseases, often, and people don't always plan for this, but there are something called Medicare Advantage plans. And they are designed to help patients save out-of-pocket costs. But often what happens is that they have a lot of exclusions in them for cancer patients, or they have a very limited provider network. And so I think that it's really important, if you have cancer, to try to stay in straight Medicare. And then what you do is buy a supplement on top of that to help control your out-of-pocket costs. And that's a better way to do that. And the Inflation Reduction Act will help Medicare patients in the future reduce their out-of-pocket costs starting in 2023 and continuing on through 2024. And they're also going to help smooth out those costs across the year. And that's something LLS and many other organizations have worked together collaboratively to try to get for patients. So that's my overview of just some different caregiver and advocacy and resources that might be available to you. And I think what's really important now is for us to be able to answer all of your questions. So if you have questions, you can feel free to put them in the Q&A box. I know we have a couple there already.
Yeah, I can take some of these, and certainly if there's others that come up, I certainly want to make sure we give a chance for everyone to ask any questions they have. Certainly don't be shy. So I'll take the first one, which is the question is, have any studies been done that correlate stress levels with disease progression? This person said that they've noticed their blood markers, hematocrit platelets, go up when they've gone through intense stress periods. Thank you. So I would say that nothing, it's hard to say things specifically. I will say that we do know that platelets specifically are an acute phase reactant, meaning that they can go up during periods of inflammation. Typically, when we talk about inflammation, though, we're talking about things like infections or surgeries, or even sometimes, anything that creates an inflammatory response, maybe exposures or something like that. And we do often see numbers change based upon that. Now, could stress fall into one of those categories? I guess it depends on how severe the stress is to some degree, because stress can do pretty incredible things to folks. But I think that in general, I think I kind of link stress with inflammation, and we know that there have been studies done on the basic science level that suggest that inflammation in many different forms can allow for the disease, myeloproliferative neoplasms, JAK2 mutated cells, when we're talking about in the basic science realm, to outcompete other cells. So if you expose cells that have JAK2 mutation to increase inflammatory markers, and you have, let's say, JAK2 mutated cells and normal hematopoietic stem cells, and you expose them to inflammation in a vial or in a dish or something like that, the JAK2 mutated cells will actually outcompete the other cells, suggesting that inflammatory pressures allow for potential progression of this disease. This actually gets to the second question by the same person, which asks, what turns on this mutation? No one in my family has anything like this, and I thought I was healthy before getting this. I think this is an interesting thought. And people often ask, like, is this a genetic disease? And the answer is it's not inherited, but we're often talking about genes, right? So it is genetic in a sense. We're worried about the genetics that are associated with this, and we often do sometimes see this run in families weirdly. So it's hard to necessarily reconcile those different kind of statements. So an interesting study was done a couple of years ago by Jyoti Mangalia in the UK and colleagues. And she took patients that had JAK2 mutations that were driving their disease and performed this very elaborate kind of a study to barcode each of their cells that had the mutation, make sure they understood other mutations that were happening, and then basically trace those cells back in time to figure out when the initial cell got the initial JAK2 mutation. And what they found is the initial JAK2 mutation probably happened somewhere between 36 weeks of gestation and 9 years old. So the first mutation in the first cell occurs early in life, which to people that study stem cell biology, it wasn't that surprising because that's when you have the most stem cell division, the most chances to make mistakes. The question then kind of translates. So now, okay, the question is not why did I get this mutation? Because I think that it happens quite randomly, due to just an or due to stem cell turnover, you start to make more copies and you have more chances to make mistakes. But the question really then extends to why does the disease come out at some point in time? Why does it come out in some people and not another? And how does this explain some of these trends we see as far as patients go? And so, I think it's very interesting. We're figuring more out about this. But the one thing I would say is this kind of helps to convey how, if we know that the mutation occurs early, we know that the disease typically occurs late, and that we know inflammation actually allows the disease to progress, then the thought would be that potentially inflammation throughout a person's life may be able to allow for this disease to progress. Okay, but then how do we explain that we have several families that multiple people have polycythemia vera, and they don't all have JAK2 mutations? One has polycythemia vera, another has ET, another has myelofibrosis. How do we explain that? And from there, we'd say that maybe it's not that you inherit the JAK2 mutation, maybe there's some sort of genetic susceptibility, similar to what we see with type 2 diabetes or hypertension or cardiovascular risk. Because this is something that maybe within a family's genetics, they have an increased risk of this developing. And so I think putting this all together, I think my working hypothesis is you have to have some genetic susceptibility. Then you have to have the right exposures. But then initially you have to have that initial JAK2 mutation or that initial mutation that happens. And if you combine those right factors, those right ingredients that are occurring at the right time, that's how you get kind of this culmination of a rare disease that occurs later in life. And so, I think it's very complicated. I think that, just like many things in science, you figure something out and you feel like you're more confused than you were before you figured it out. And this study that was done has really led to a ton more questions, maybe an increased understanding of the disease, but also just a lot more questions about how can we, and really some of this is optimistic, right? So maybe our goal isn't preventing the JAK2 mutation. Maybe that ship has already sailed, but maybe our focus is on identifying this JAK2 mutation early when it is present, and identifying which patients we need to focus on decreasing their inflammatory load. We know that inflammation is key. We know that smokers and patients with inflammatory bowel disease and patients with autoimmune diseases and patients that have specific genetic factors that increase their basal level of inflammation, those patients are more likely to get MPNs. If we can identify those that have early JAK2 mutations or maybe other mutations, perhaps we can come up with ways to prevent their disease progressing if we're able to identify it earlier. So that was a very long-winded answer to those two great questions. But I'm looking to see if there's any other questions from folks. Again, use that chat box at the bottom if you have anything to chime in.
Amanda put a question in the chat box for you, Dr. Kuykendall. I have a lot of bruising all over my body. It feels like I have a swollen spine. Is this an indicator that my PV is progressing?
So I guess we'll come back to the question of what are the symptoms of disease progression? Like if PV progresses to myelofibrosis, what can you expect or how do you know that? I think that's a common question that people ask. First off, as I mentioned, this is kind of a natural progression to some extent, right? This is kind of what we would expect to happen at some point, but it happens at different rates in different people. And some people, maybe that trajectory would happen over 30 or 40 years, and other people, maybe it's something that would happen over the course of 5 to 10. Everyone's different from that standpoint. But what we see often happen with polycythemia vera progression, a lot of it's in the lab work, right? So we see patients that were needing a ton of phlebotomies or had a hematocrit that was relatively well controlled on a specific dose of hydroxyurea per se. Maybe they no longer need phlebotomies, or maybe their blood count starts dropping on that dose. And even if they decrease the dose, the blood count still goes down. Now they're getting more anemic. And that often is a sign that maybe this disease is progressing to myelofibrosis. Other things that can happen is you start to develop more symptoms, fevers, chills, night sweats, bone pain, more of these constitutional symptoms. Other times people can feel like their spleen is growing, right? So maybe they are always, it helps a lot of times to understand baseline values for this disease. Like that's why I always encourage getting a bone marrow biopsy early on, right at diagnosis of polycythemia vera, so we know what it looks like there. Similarly, I think it's good to at least have a good exam of the spleen, or at least maybe an ultrasound of the spleen to understand how big it is, so that if you do feel symptoms, you can kind of check it again and see if it's truly objectively grown. Because I'll tell you, our physical exams in the clinic are pretty poor as far as reliability goes, and especially if you're getting examined by different people, it's hard to rely to say that that's a good way of judging disease progression. So, I think that these are all different signs of how you can tell if the disease is progressing. Ultimately, a bone marrow biopsy is going to be what really defines that. Are you seeing increased scar tissue and fibrosis in the marrow? And there's actually specific criteria you meet for knowing if you have post polycythemia vera myelofibrosis. And it includes an increase of that scar tissue, but also it includes things like anemia or immature blood cells floating around, or big spleen that's new from prior. Because as we mentioned, spleens can be enlarged in polycythemia vera too, maybe new symptoms as well. So potentially as far as the spleen goes. Now you mentioned the bruising. That is actually just very common in patients with polycythemia vera or any myeloproliferative neoplasm. Bruising, you actually get kind of platelets that are dysfunctional that increase bruising. It's also common in patients on aspirin, which most people are on. It's also common in patients who are on ruxolitinib that increases bruising. So there's a lot of reasons for bruising. Certainly you want to get blood count checked, because if you have really low platelets, that would be a concern that could lead to the bruising. But certainly, there's a lot of other reasons why bruising could be occurring. Hopefully that answered some of the question that was listed there. I see another one here as well. So this one says, do you know of any open clinical trials right now, or where I can find more information? Is everyone with a PV diagnosis a candidate? So to answer the second part of the question first, no, not everyone with a PV diagnosis is a candidate for each specific trial. Each trial is designed very differently, and it's there to really benefit a specific subgroup of patients based on what we think the drug is going to do. So there are various different polycythemia vera trials going on, and they can be present at different locations. There's different ways to find out about them. One way is have a PV specialist. It's always nice to see a physician who specializes in myeloproliferative neoplasms. Even if it's just a one-time visit, they can become a resource for you throughout the entirety of your disease, right? Even if you only see them, as needed. But often they'll know what trials are going on, and potentially will know where they're going on. There's also a website called clinicaltrials.gov, where you can go and type in polycythemia vera, and it'll give you a list of a bunch of trials that are ongoing, and you can use some different filters to identify the trials that are currently enrolling. And it will actually list at the bottom the sites where the trial may be open. Now, it's not perfect by any means, but it may be a good jumping off point to try to identify where a specific trial is ongoing. And it's a good way to peruse to try to get a sense for what clinical trials are open. As I mentioned, there's a few ongoing later phase clinical trials. Certainly the rusfertide trial, looking at this drug called rusfertide, PTG-300. This is an ongoing study. We have it open at Moffitt. It's also open in South Florida at one institution, as well as a few other institutions as well across the U.S. And even in Europe as well, I believe. But yeah, so you can. There's many websites. If you Google rusfertide or PTG-300, it'll take you to a variety of different websites that the company, which is called Protagonist, is running the trial that gives you a lot of resources and information about where that goes. And there's other trials that are ongoing with polycythemia vera. People are looking at optimizing the dose of ropeg interferon. People are looking at an agent called bomedemstat in polycythemia vera. But again, these are smaller trials that are at different centers, and so it's always helpful to have an expert that can look these things up and figure out if a trial is open near you and makes sense for your specific disease. But really, it depends on what you're looking for, from that standpoint.
I put in the chat box the link to our clinical trials support center that you can complete the online request form. And our nurses really work with you. They spend usually 30 to 45 minutes on the phone with you discussing your goals of treatment, what you want to do, narrow down those searches. They'll get in touch with your doctor if you want them to, and really work with you and then bring you a good list of information to take back to your doctor to say, hey, here are some clinical trials that might be helpful to me in my area. But they'll also look, if you have family who lives in a particular part of the country and you're like, oh, it'd be convenient to go there, they'll narrow down things like that. So they work with you really closely. And then if you decide you want to enroll in a clinical trial with your doctor, then they do work with you to figure out how to get you enrolled in that trial so that it doesn't put that on the doctor if it's not a trial that they have open at their institution. So we really work closely and collaboratively with you in the way of doing that. And it's really a much simpler process when you have an educated advanced practice nurse who's really doing all the legwork for you and your physician to really make sure that you have that support and are well educated on what a clinical trial is and how to get into it.
That's perfect. Yeah, I think there are a lot of people, there are a lot of different ways to get access to trials and a lot of people that are willing to help. I think that in the MPN community, this is a very motivated community. Seth had mentioned the help that LLS has. I think some of those resources he mentioned earlier, as far as PV Reporter, MPN Advocacy and Education International, if you reach out to them in any of their forums, tweeting, email them, they're very motivated to try to help. We understand that this is a disease that really benefits from clinical trials, and we're happy to try to put you in touch with them if we can. I see a few more questions came through. One that I see from the chat is, I am told that exercise helps with polycythemia vera, but I often feel tired, shaky, depleted, and get really itchy. Any suggestions? Yeah, this is tough. I mean, I think that the main symptom that people complain of that we're unable to help significantly with is fatigue associated with polycythemia vera. And you get into this really nasty loop where if you're too fatigued, you don't exercise, you don't sleep well, which then makes you more fatigued, and then you kind of this nasty cycle. I think in general, I think the itchiness is probably the thing that we can help with the most, right? I mentioned that ruxolitinib is a great drug for itch, but I've had many patients who's itching, we call it pruritus, has been improved with hydroxyurea. So I think getting the itchiness under control can help. Especially heat tends to exacerbate itch when the blood counts aren't as well controlled, and can certainly be alleviated with the right medication. So I think getting the itchiness under control is probably the thing that's probably the most accomplishable of what you said. The other mention is here, just the tired, shaky, depleted, feeling like crap. I think that's a common PV feeling, and I don't have great explanations for that or great ways to improve that. I think certainly we talk about optimizing sleep, healthy diet, understanding limits, really kind of trusting your body to some extent. I think that patients often describe their fatigue as something when they wake up, they have a decent amount of energy. However, they seem like they're worn out by 11. They try to push through, but then they pay for it a few days down the road. I think that many of our patients say that the best way they've had to deal with that is to just try to get all their important stuff done in the morning. Sometimes if their body tells them to take a nap, they take a nap and they have more energy when they wake up from it. Ruxolitinib is thought to help some with fatigue. I would say it's an incomplete assistance with that symptom. We still have patients that have a ton of fatigue that are on ruxolitinib who wish that it helped more than it did. We advise kind of non-pharmacologic interventions such as yoga, mindfulness, again, exercise. I think that if you're able to do it, try to do as much as you can, but really don't push it, and try to do little by little more and more, and see if it's something that gets better over time. But it really can be a challenge, and I certainly don't mean to underestimate the challenges that can play, because that's something that really, we know that fatigue is common, and it's probably the symptom that impacts quality of life the most. See another one here says, my provider keeps my hematocrit greater than 45 to help prevent me from being tired. Is this increasing my risk for blood clots? I think obviously every patient's different. I think from our data, we know that keeping hematocrit less than 45 tends to reduce the risk for thrombosis. I don't think that really, I have often seen fatigue that exists at those levels. I think that fatigue certainly can set in if you get more anemic, but often with a hematocrit of 43 or so, your hemoglobin's fine at 12, maybe 13 even at that realm. And so, I would still favor trying to protect you from blood clots by keeping the hematocrit better controlled. And then, as we mentioned, fatigue is inherent within the disease. And so, I think it's kind of agnostic to blood counts many times. The fatigue really comes from the fact that you have this inflammatory disease. I often liken it to like how you feel when you have a bad virus, or whether it's COVID or just a bad virus. I have 3 young kids. I've had bad viruses a lot recently. And when you have bad viruses, you just don't feel like going and doing anything. You just feel kind of worn out. And the reason is because you have these inflammatory pathways that are activated, right, that are fighting that infection. Unfortunately, patients with polycythemia vera have those same inflammatory pathways that are activated every day, all day. And so it's not uncommon to think that they have some degree of fatigue and not feeling like they want to do something. But I don't think that there's necessarily a correlation between a hematocrit above 45 or less. That being said, everyone's different. There are some patients that have symptoms at specific values that we need to be certainly conscious of, and you need to work together with your physician to make sure you're, at the safest blood level for you that maximizes your quality of life. I see another one here that says, regarding hydroxyurea, is there a low and maximum dosage or time limits on this drug? So every dose is different. I see that Seth has put something in here in the chat talking about resources and other helpful organizations as well. So as far as lower max dosage for hydroxyurea, every dose, this is something that has a lot of broad dosing. We picked the right dose. I think I have patients on as little as 1 tab, every other day or a couple days a week, to patients that are on, 3 tabs twice a day. And so it just depends on what you need, right? And that's one of the good things about hydroxyurea is that it's easy to titrate the dosing and figuring out what works. My goal is to control blood counts as best as possible without causing side effects. And so that's a conversation we have with each individual patient. There are patients where we say, okay, I can't tolerate more than 2 pills of hydroxyurea a day, or else I get mouth sores or fatigue or some sort of GI side effects or something like that. But if they're on 2 pills a day, they feel completely fine. So in those patients, let's leave them at 2 pills a day. If that means they have to have a phlebotomy once every 3 months, fine, right? I'm not going to try to put them through hell just to get rid of that, once every 3 month phlebotomy. At the same time, if they run into side effects, maybe we consider alternative therapies, right? We have another 2 agents we can use there, and so we can consider those. As far as time limit on the drug, not really. I think we continue to work it, use hydroxyurea until we feel like the risks outweigh the benefits. But this is a drug that many patients are on for years and years and years at a time. We've got many patients that have been on hydroxyurea for upwards of a decade or 2, right? And so it's not something that certainly wears out. Sometimes the disease gets more complicated and we need something different, or sometimes there's side effects that emerge, but it's not something that has a strict time limit. Another one we have here, the question says, with across the board anemia and cell volume, cell size, cell color, is there any anemia help out there? So let's kind of talk about what anemia is. So anemia is really talking about a decrease in red blood cells, and hemoglobin, which is the protein that carries oxygen, is one way of defining anemia. If you don't have enough oxygen carrying capacity, then that's one way to define anemia. Unfortunately or fortunately, when you get a CBC, they give you all these different values. You don't just see the red blood cells and the white blood cells and the platelets. You also see things like mean cell volume, or MCV. You see the red cell distribution width, or the RDW. You see the mean cell hemoglobin, or the MCH. You see the mean corpuscular hemoglobin concentration, or the MCHC. A lot of these things are really not necessarily useful within the context of polycythemia vera. They're useful for other conditions or benign hematologic conditions, but they're there, and oftentimes they're abnormal. But it's not a problem if they're abnormal. And so what I can tell you is, when we talk about things like MCV, oftentimes if your MCV is low, that means that you're iron deficient, We know most people with polycythemia vera are iron deficient. That's actually a goal in some ways because we're doing phlebotomies on them and they become iron deficient, so their MCV is low. That's going to show up in their mean cell volume and cell size. That's going to change the color of their cells because they're going to be hypochromatic. But that doesn't mean that's a problem, right? That's just something that we know goes along with that. Again, when we talk about anemia, we're just talking about, you know, the oxygen carrying capacity of your blood cells. And so, you know, I think sometimes we have to kind of not ignore, but understand that some of these other things that show up in the CBC aren't as clinically relevant for this disease. I do see a question here that says, what is the difference between hematological and molecular remission? My allele burden started at 67, it's now 17. Awesome. Am I possibly heading towards some type of remission? I don't know. I think that when we talk about hematologic remission, we don't really talk about hematologic remission. We talk about hematologic control or hematologic response. So in trials, we'll talk about CHR, which is a complete hematologic response, which means are my blood counts normal or within relatively normal limits? So that's nice. But when we talk about remission, I think there's two ways to think about that. We could talk about morphologic remission. So morphologic remission is if we looked at the bone marrow and now the bone marrow looks normal. So it's no longer hypercellular. You no longer see panmyelosis, these increased production of all these blood cells. You have a normal cellular bone marrow with a normal amount of megakaryocytes. That would be a morphologic remission. A molecular remission is if we can no longer find the mutation that drives the disease. And so what I would say is in many diseases, when we talk about molecular remissions, we're talking about we can't find the mutation at like 0.0001% or 0.01%, right? At really, really low levels. In PV, we're certainly not there yet. You know, we get excited if it gets less than 10% or less than 5% or less than 2%. It doesn't mean that you're in, and for that reason, it's hard to say if it's truly a molecular remission because I don't think that's well defined within the context of polycythemia vera. What I would say is it's certainly encouraging that the amount of cells you have that have the JAK2 mutation has gone down from 67% to 17%. To me, that means that something is happening that means that most of your blood cells now don't have that mutation. So you have, presumably, most of your blood cells now have no mutation, right? They're normal blood cells or come from normal hematopoietic stem cells. So something, whatever treatment you're on or whatever is occurring is allowing these kind of normal cells to outcompete the others. The question then becomes, does that mean we can stop treatment? I don't know. Whatever treatment you're on seems to be working. So I'd hesitate to, yeah, so you're saying you're on interferon. I'd hesitate to stop using the agent that's doing that, but certainly you could talk about maybe spacing it out or something like that. If you're tolerating it well, I'd probably just continue doing what you're doing, and that's what I typically advise patients is, you know, if whatever agent you're on is allowing this positive impact to occur, I would continue that. However, if you were to have side effects or didn't tolerate it very well, you know, you could certainly talk about alternative dosing strategies to see if that response is maintained if you start taking it, you know, less frequently or a lower dosage. But I would only do that if you were having difficulties with tolerating it and we felt like we were going to get some quality of life benefits from that. I'm not seeing too many other questions in there, Seth. I'm not sure on your end. Are you seeing anything? I missed some before, but I think you're on mute, but yep.
Sorry, I'm mute.
Yeah.
Yeah, I don't see any other in the chat or in the Q&A box. I have them both open, but I don't see any others.
All right. Well, I will then we can move on and say I think that I was first thank everyone who submitted those questions. I'll kind of defer over to Amanda to see if we have anything else that we need to cover today, or is that going to be good?
We're all set. Thank you guys so much.
So again, I'd like to thank Seth for being here, presenting this evening, leaving us with this meaningful information. I do want to once again thank the folks from PharmaEssentia for sponsoring this webinar. As a reminder, all the handouts mentioned in this webinar, all the different links are there in the chat box. And this webinar was recorded, so if you missed anything and want to hear it again, it will be available on FLASCO website soon. Thank you all for joining us tonight, and we really hope you'll join us for more webinars in the future. And thanks so much. And feel free always to reach out or come see us at Moffitt if you have any questions, and we're always happy to see you in the clinic and go from there.
Thank you guys. Have a great night.
Thank you.
Thanks.
Thank you for
Good
having
seeing you,
us.
Seth.
Good seeing you too.